we are at the tipping point for a new way of thinking about treating inflammation using electrons instead of drugs.
Welcome, everybody. This is Buck Joffrey with the Longevity Roadmap. And today I have a really fascinating conversation. Dr. Kevin Stacey is a neurosurgeon. He's actually more famous as an immunologist. Discovered a major reflex involving the vagus nerve and the immune system, and ultimately sort of the father of bioelectronic medicine. If you've heard of vagal nerve stimulators, etc., that is all. This is a guy who started kind of that entire area. Really fascinating conversation, as you'll realize there is a huge opportunity with the kind of work he's doing. He talks primarily about the role of the vagus nerve as it relates to the immune system, and specifically as it relates to chronic inflammation. And as you can imagine, that is affecting pretty much every major chronic disease, pretty much everything that ails us. So this conversation becomes incredibly relevant, not only for Healthspan, but longevity. Anyway, I can't say enough about it. Really fascinating interview, and we will have that right after these messages.
Hey, longevity enthusiasts, it's time to take it to the next level. I've been fine-tuning my longevity regimen for years, and I look better and feel better than I did a decade ago. In fact, my blood work is even better than it was back then. And it's all because of my data-driven regimen, and it's inspired me to create a course and community just for you. It's called the Longevity Roadmap, and I urge you to check it out. If you're tired of your belly fat, tired of being tired, or just want to optimize yourself for the next 50 years, visit longevityroadmap.com. That's longevityroadmap.com.
Welcome back to Longevity Roadmap. Today, my guest is Dr. Kevin Tracey. He's a neurosurgeon and an immunologist and globally recognized pioneer in the field of neuroimmunology and bioelectronic medicine. He received his undergraduate degree in chemistry from Boston College and an MD from Boston University, and trained in neurosurgery at Cornell, and has also served as director of the Laboratory of Biomedical Science at the Feinstein Institutes before becoming its president and CEO. Dr. Tracey's best probably known for discovering the inflammatory reflex, which is a neural circuit that shows how the brain regulates the immune system through the vagus nerve. His groundbreaking work has led to new therapies for chronic inflammatory conditions and launched the field of bioelectronic medicine. He is also one of the most cited researchers in immunology and the author of over 400 scientific papers and multiple books. Dr. Kevin Tracey, welcome, Kevin. How are you?
I'm good, Buck. Thanks for having me on. It's great to be here.
Well, it sounds like you've been doing quite a bit. We talked a little bit offline. We shared the neurosurgery background a little bit. And you trained as a neurosurgeon, but ultimately became one of the most cited immunologists in the world. So just in general, what drew you to the immune system? What sparked your interest in exploring its connection with the brain?
It's interesting, Buck. All my life, I wanted to be a scientist, looking at how the scientific method could reveal discoveries that could help patients. And so as I made my career decisions, first to study chemistry, I thought maybe I'd be a medicinal chemist. Rather than do the PhD route, I decided to go to medical school to really dive in to understand the patients themselves and the disease mechanisms. In medical school, I made a choice to pursue surgery because I've always loved working with my hands. And once on the surgery path, I chose neurosurgery. So that was the career path. The choice of pursuing the research path in inflammation really came about because of a patient I met when I was training to be a neurosurgeon. A little girl named Janice, 11 months old, died in my arms. And she died after a household kitchen accident. She was scalded by accident. And she died of overwhelming condition, it's called septic shock. And at the time this happened in 1985, there was no explanation as to what caused her cardiovascular system to collapse. The dogma then was that toxins made by bacteria cause septic shock. But I knew from taking care of her, she didn't have any evidence of infection. And there was no way to measure these toxins. And so within a month after she died, I started my research training and I decided I would study the the problem of inflammation that killed her. And that really, my colleagues and I, within a few years, had identified new molecules that today we call cytokines, like TNF, as the cause of that kind of shock. And so I've been pursuing this question since 1985 of the molecular basis of inflammation.
Yeah, and actually, you're credited with the discovering of this inflammatory reflex, right? The idea that the brain can regulate the immune system through the vagus nerve. For our audience, walk us through that discovery, because it sounds of the beginning of it sounds like the story that you just mentioned, right? But what is the pathway? Like, what were the steps in the research? Tell us the story.
The story continues from understanding that Janice died because her immune system overreacted to something and made too much TNF, too much IL-1, too much IL-6. Today we call that cytokine storm. And so from that knowledge, it really frames the next question. Most people walk around and produce the right amount of cytokines. The right amount of inflammation is clearly beneficial. The right amount of inflammation is essential for wound healing, for recovering from injury, and for warding off and fighting off infections. So thinking about this for a minute, the real question becomes, why sometimes does the immune system overproduce cytokines? And this occurs, we know today, it occurs not only in the dramatic case of septic shock, but it occurs chronically in rheumatoid arthritis and inflammatory bowel disease and in psoriatic arthritis and multiple sclerosis and other conditions, metabolic disorders. I mean, it's a chronic inflammation is a contributing cause of some cancers and some heart disease and some stroke. So the question is, when the immune system evolved to produce inflammation as a beneficial response, what other systems evolved to control it and prevent it from spinning out of control? So that's the background. What really happened was unexpected. By day, I was in my clinic tapping knees and looking at reflexes, and by night, working in the laboratory and on weekends, thinking about these mechanisms. During the course of the laboratory studies, we developed a molecule that was an anti-inflammatory molecule. It would shut down cytokine production. And it was a very, very potent molecule, and we wrote dozens of papers about it. We thought we understood how it worked by blocking a signaling pathway called P38 MAP kinase. And to make a long story short, one day we put this molecule into the brains of rats with a stroke. And the idea was this molecule in the brain would shut down the inflammation around the stroke and reduce the amount of neural damage. And that all worked. It worked beautifully. What we didn't expect, and was a complete surprise, was when the molecule was in the brain to shut down inflammation in the brain, it also shut down inflammation in the body. And this was a real surprise. So we called it CNI 1493. It was a tetravalent guanyl hydrazone, which means it had these 4 arginine-like charged moieties on it. And we had made this as part of a screen of chemical molecules we were working on to be anti-inflammatory. That molecule today is called cimapimod, and it's still an experimental therapeutic that's used in some research studies. That molecule, cimapimod, I mean, the joke we used to tell is it was very, very good to us. You remember the Saturday Night Live skit, baseball has been very, very good to me? Well, it turned out that molecule led us to the vagus nerve, because what we learned it took many years later when we put all the pieces together, but what we know today is that molecule was activating neurons in the dorsal motor nucleus of the vagus nerve, which were sending signals down to the immune system to stop inflammation. That really paved the way to mapping today what we call the inflammatory reflex. And the obvious experiment, I mean, if you know the vagus nerve is functioning like the brakes to your car to suppress inflammation, and this was in the mid-1990s, and at that time, the FDA had already approved vagus nerve stimulation to treat epilepsy. So I knew it could be done safely in patients. So I wrote on the back of a napkin, electrically stimulate the vagus nerve to downregulate inflammation and treat rheumatoid arthritis and Crohn's disease. And those were the original ideas behind the original patents that we filed. And when we did the experiments, they worked beautifully. So we wrote a couple of papers in Nature and later on papers in Science and other journals describing in exquisite detail how these cholinergic signals arriving in the dorsal motor nucleus of the brainstem travel down into the abdomen, where they synapse in the celiac ganglion superior mesenteric plexus, which is the origin of the splenic nerve, to activate adrenergic fibers in the splenic nerve, which control a T cell subset that we call T-chat because they express choline acetyltransferase, which is the enzyme that is the rate-limiting enzyme in the biosynthesis of acetylcholine. That acetylcholine made by the T cells is what inhibits the production of cytokines by macrophages and monocytes. And so because this has been mapped in such exquisite detail by my colleagues here at the Feinstein Institute and now by dozens of labs around the world, it has enabled a lot of people to start thinking about how to hack into this system to treat patients.
So it's interesting that, I mean, when you talk about this, I mean, quite frankly, I didn't really know this. And as much as I have spent time in this space, just learning about longevity and inflammation and interviewing people at the Buck Institute, this is the first time I'm hearing about, this direct correlation of the vagus nerve and the immune system. Just for people who you went into a fair amount of detail, but big picture, you have stimulation of the vagus nerve that is effectively downregulating the immune system, right?
It's downregulating the
inflammatory process, at least.
It may be doing a lot more things, but what we know for certain now and have studied in exhaustive detail is this reflex, the inflammatory reflex, is based on some number of fibers in the vagus nerve that reduce the amount of inflammation from the toxic level to the healthy level. It doesn't immunosuppress. There's no evidence of immunosuppression in more than 250,000 patients that have been studied with vagus nerve stimulators for epilepsy. It reduces the burden of inflammation from the dangerous level and brings it down to the safe level, which is how you would imagine. That's what the evolutionary pressure would be to restrain the severity of the danger without causing a new danger in the form of immunosuppression.
Yeah, it's pretty fascinating to think about it that way. So tell us about the work around this. I know you've done some work in as it relates to rheumatoid arthritis.
I think it's an incredibly exciting time, and depending on when this podcast airs, by the time this podcast airs, I fully anticipate that the FDA will have approved vagus nerve stimulation for the treatment of rheumatoid arthritis in patients who have not responded to available biologics and other therapies. And the reason I say that is because a company that I co-founded called SetPoint Medical has completed its clinical trials, and the FDA is now reviewing the data from a trial that was reported out last November at the American College of Rheumatology. This trial involved some 242 patients at more than 40 medical centers around the United States. And the primary endpoints were designed as if it was a new drug. And these include things like the ACR20 score, which is the 20% improvement score based on the American Rheumatology's metrics for looking at pain and swelling and quality of life. And there's even some measures that include some serum markers, and there's actually been additional measures looking at MRIs of the resolution and healing in the joints. So all of this data now has been reported out at the American College of Rheumatology, and the manuscripts are being written as we speak. So what that means, if the FDA approval comes through as I expect it will, it means that patients will, in the coming weeks and months, when the product rolls out, be given the option of having a chip the size of about a multivitamin implanted in their left neck at about the level of the Adam's apple on their vagus nerve. Once it's implanted under the sternocleidomastoid muscle through an incision about 1.5 inches long, the device will fire for about 1 minute a day. When it fires, in some patients, they don't feel it. Some patients have slept through it when the device was set to fire at 4:30 in the morning. Other patients wake up and it feels like a little buzzing in their neck. The reason it works, and I think we can back up a little bit, is we talk about the vagus nerve. Your physician listeners will all know this, but others might not realize there's two vagus nerves, like two thumbs, and that each vagus nerve on each side has 100,000 fibers. Now, each and every one of those fibers has a specific origin and insertion arising in the brain or brainstem and traveling down to all the organs in the chest and abdomen that we don't think about all day long. 80% of the 200,000 fibers are sensory. They send information into the brain, and 20% account for the signals traveling from the brain down the vagus nerve to the organs. This is the basis of reflex arcs. So an input to the brain activates an output. And we estimate of the 200,000 fibers that about 100,000 fibers, 1,000 fibers, and maybe significantly less, are sufficient, necessary and sufficient to suppress this inflammatory damage. So when the device fires for 1 minute a day at about 400 microamps, which is a very small amount of current, that's sufficient to activate a cascade that has a half-life of around 12 hours. So you get this long-term benefit from this short little pulse of activating the inflammatory reflex.
When I'm thinking about that response that you're going to get from that, obviously you've been talking about rheumatoid arthritis, but you mentioned Crohn's. I'm curious what other disease processes are currently being studied, heart disease, neurodegeneration, perhaps. Can you give us a little background on that?
Yeah, the background is really important, that the focus is on inflammation for those conditions, because otherwise it starts to sound like snake oil. I think to close the loop, this therapy, by downregulating severe inflammation, I think is likely to help many patients with severe inflammation not controlled by drugs, but not all patients. Like all therapies, therapy like this will probably have a significant benefit in some number of patients. No benefit, unfortunately, for reasons we probably will never completely understand, in other patients. And then in between, you'll have patients who have some benefit, but not as dramatic as those who, as we've already seen in some patients, who no longer need to take any medications. Their only therapy for their rheumatoid arthritis in a number of patients, and I've met many of these patients, their only therapy is the vagus nerve implant. So if that's the background for rheumatoid arthritis, that's where we have the data. And you asked specifically, where's the research interest? There's tremendous interest in inflammatory bowel disease, because once again, we have some positive clinical trials. I estimate there's been between 25 and 50 patients, maybe 100, but not more, that have had vagus nerve stimulation therapy for Crohn's disease and ulcerative colitis. And there's some very significant and interesting clinical results from those studies. So I fully expect you're going to see a lot more work in that. When you move into the research area, there have been vagus nerve stimulation studies in diabetes, believe it or not. These have been done primarily using focused ultrasound targeting the porta hepatis of the liver, where there are vagus nerve fibers that are glucose-sensitive fibers. And so the focused ultrasound on those fibers tricks the brain into thinking glucose is spiking up, which activates neural pathways to drive insulin secretion. And so there's a lot of interest in that kind of work.
Yeah, interesting. I was mentioning metabolic syndrome earlier. And one of the things that, that happens there is you get this elevation, high sensitivity CRP, which, a lot of people used to monitor. Presumably that's the kind of thing that you could potentially affect, right, with vagal nerve stimulation?
Exactly. So I think we run into a semantic problem. I think you would agree with me. Let's talk about that for a second. So what is the definition of inflammation? Inflammation, Galen defined. Hippocrates talked about it. It's heat, it's pain, it's redness and swelling. And now, as we've gotten into the modern era since the 1980s and the discovery of cytokines, TNF, IL-1, IL-6, and eicosanoids and prostaglandins, now we look at the molecular mediators of inflammation as inflammation. And so when you talk about, and everybody does, the contribution of inflammation to metabolic syndrome, to insulin resistance, to obesity, there's very clear evidence in mouse studies and in human studies that there is a quote upregulation of the production of inflammatory mediators in specific tissues like adipose, sometimes in muscle. It depends on the studies. So now we're calling that inflammation. But here's what it's not. That inflammation is not in the tissues heat and pain and redness and swelling. It's a molecular form of inflammation, and people have tried giving it different names like meta-inflammation or specific names like the inflammation of insulin resistance and that kind of thing. So understanding that, the question becomes, if we know, because it's all about asking the right question, right? If we know that signals in the nervous system can regulate the expression or the activity of various cytokines and various inflammatory molecules, can we send those signals to the tissues that are causing the insulin resistance, like skeletal muscle, and can we change the metabolism of adipose tissue or the insulin sensitivity or resistance by modulating the expression of cytokines in specific tissues? So those are the kinds of questions people are asking. The answers are not all in. Where I do predict you're going to see new clinical trials very soon, probably by Setpoint Medical, is in multiple sclerosis. And what's so interesting about the preclinical data there, which my colleagues and I were collaborators on a study in the Proceedings of the National Academy of Sciences a year or two ago, we saw that vagus nerve stimulation in the animal model of multiple sclerosis called EAE, it did two things. Not surprisingly, it reduced the amount of inflammation, and that prevents the progression of the damage in multiple sclerosis. So that's great. What was surprising and really important is that the vagus nerve stimulated animals also had accelerated remyelination, which is obviously crucial for healing and for regaining the function of the nerves that were undergoing demyelination. So if that holds up in humans, which we will only know after clinical trials, if that's possible in humans, that would be a significant therapeutic advance.
So, you hear a lot these days of the concept of inflammaging, right? So we've obviously talked already the low level inflammation that's happening, at these multiple organ levels. But ultimately the concept with inflammaging is that low level inflammation simply increases with age. It's now potentially considered a central driver of biological aging, or a big contributor. Do you think dysfunction of the inflammatory reflex contributes to the process?
It might. It very well might. Again, a great testable hypothesis. Once you understand these circuits exist and they're real, now the question is, how can we measure them? And there we run into a little bit of a limitation in human studies. In animal studies, the answer is quite clear. Vagus nerve fiber activity, if you will, or vagus nerve function declines with age. And as you point out, the triggers to inflammation or the severity of inflammation increases with age. And that seems to be true in humans as well. Proving the mechanism, correlation is not causality.
Sure.
And proving the mechanism in humans is difficult because we don't have great surrogate measures for vagus nerve activity. People put a lot of weight on heart rate variability as a measure of vagus nerve function. Now that depends, right? It depends on the algorithm. It depends on how the data are collected. So putting some caveats in place, what's fascinating to me is that there is very clear evidence that conditions of inflammation are associated with decreased heart rate variability that point to the possibility that vagus nerve dysfunction or impairment is contributing to the excessive inflammation, like the brakes failing on the car. But it doesn't prove it, because it is also possible the inflammation damaged the vagus nerve. Now, where that really becomes interesting, and we probably have some of the clearest data, is actually from COVID. At the end of the COVID pandemic, a couple of studies came out of, they began in Madrid, Spain, and have been replicated in other places. But in autopsy studies of patients dying from COVID, careful examination of the vagus nerves in some patients found evidence of the virus in the vagus nerve and evidence of vagus nerve damage and inflammation. And in subsequent studies in long COVID patients, there's pretty good evidence from high resolution ultrasound studies and fMRIs of vagus nerve damage. So it leaves the question, makes a very real question. Is it possible that the vagus nerve damage is unleashing, if you will, the inflammatory damage that's coming downstream? And we definitely know from physiological studies in long COVID patients that there's clear evidence of autonomic dysfunction.
Yeah. Interesting. When you think about things that people are doing these days in, I don't want to call it the biohacker world necessarily, but people like who are trying to prevent disease and that kind of thing. Do you see a day potentially with some type of technology, vagal nerve technology, that might be used as preventative?
I do. And let's back up to your favorite topic, longevity and health span. And let's start with the basics. So every year on planet Earth, 60 million people die. 40 million of those people die of heart disease, stroke, cancer, Alzheimer's, neurodegeneration, metabolic syndrome, diabetes, obesity, and infection and autoimmune conditions. Those conditions I just said, every one of them has either as a root cause or a contributing factor the presence of severe inflammation. And today, we can't cure inflammation. There is no cure for inflammation. I spent a lot of time in the last few years imagining, what if we cured inflammation? What if we cured inflammation? Now, we can't today, but there was a time we couldn't prevent smallpox and we couldn't cure strep throat. What if we could cure inflammation? If we could, what would happen to Healthspan if the people today dying of some of those conditions didn't die, and if the trajectory of those conditions was either attenuated or even reversed? So it's a really, really important idea that understanding how the nervous system controls the inflammatory response or the immune system might hold the key. Now, if that's the case, as a physician, you would have to agree, I think, can you think of a condition where treating it late is better than treating it early? No.
Right.
I can't either. So if that's the case, and you have people putting magnets under the skin of their hand so they know which way north is, and you have other people putting chips in their skin so they don't have to carry their keys around and they can swipe their way into their office door. People are signing up to put stuff in their body, as you said, already, and they're putting in sensors, and that you can buy over the counter now, right? Glucose monitors that you stick in yourself. Do I think people are going to look for devices they can treat inflammation to prevent these chronic conditions in the coming years? I absolutely do. I don't recommend any sort of self therapy with modalities that are not FDA approved and under the guidance of doctors and surgeons. But do I think that day is possible to come someday? Yeah, I do. I think there are hundreds of people working in dozens of labs and companies right now on these ideas, because the basic science is clear. There are neurological circuits that can be harnessed and regulated with small devices to modulate the immune system. Now the question, we're limited only now by thinking up the right questions and doing the right experiments. The engineers, the biomedical engineers, have already made devices we could barely imagine, and they're working on devices we can't even imagine right now, nano devices and other things. So yeah, I think it's possible that will happen. I don't know when. I'm not a futurist. I don't have a crystal ball, but the data are clear. We are at the tipping point for a new way of thinking about treating inflammation using electrons instead of drugs. And that will drive, I think, a lot more work in this.
So, it's interesting because in this space, there are these companies already that claim to stimulate the vagus nerve through, externally applied technologies. I guess the first question is, what's the limitation of those kinds of devices as opposed to doing a surgical implantation device? I mean, obviously, you're getting under the sternocleidomastoid, you're getting closer in proximity to the vagus nerve, but what are the limitations for a, cutaneous or, transcutaneous device?
So we could talk about this for hours. And again, I think we have to agree on some basic definitions because the words are really important here. So there's only two ways to stimulate the vagus nerve directly. One is to put an electrode on the vagus nerve, and that can be done surgically. The only way to do it non-surgically, to put the stimulating agent, the stimulating factor, directly on the nerve, is with focused ultrasound, which goes through tissues to a significant depth and can be focused. Now, that's still experimental. It's not broadly available. And implantable vagus nerve stimulators have been FDA approved for decades. So that's the ground rules.
And just to be clear, the surgical ones, are they going right on the nerve then?
Yes.
Are you putting, okay.
Yes.
Got it.
So I call them the Gen 1 devices, which go back to the 90s in the early epilepsy therapy cases, and which are still being used today, actually. They're almost like slinkies that wrap around the nerve, and that has to be put on very carefully because you can damage the nerve. The new device, the Gen 2 device, I call it, which is the set point device that should be, as I said, FDA approved by the time this podcast comes out. That device, as I said, this is about the size of a multivitamin. It's fully contained device with a battery, a computer chip, an ASIC, leads. The leads are two metal strips that actually touch the nerve, and antennas. The antennas communicate with the doctor's tablet so that this is fully adjustable and controllable in the doctor's office through an iPad. Those are the only devices that directly stimulate the vagus nerve. People talk about electrodes on the skin, which are basically TENS units, and they call those vagus nerve stimulators because they put them somewhere. And biomedical engineers have a real problem with that. There's no direct evidence that the commercially available devices that call themselves vagus nerve stimulators that go on the skin, there's no direct evidence that they're stimulating the vagus nerve. Now, let's be clear. When you put electricity on the skin, you stimulate nerves. And those nerves, you can feel them. You feel the buzzing. Those nerves send signals into the spinal cord. If it's on the head or neck, it stimulates cranial nerves. And all those signals go into the brain. Agreed. The brain has 100 billion neurons, trillions of synapses, and essentially, as Charles Sherrington taught us in the 19-teens, all the neurons in the body are connected, ultimately. So if the brain takes that incoming signals and wants to send out, which it does do through reflexes, send out outgoing signals, fine. Some of those signals may go down the vagus nerve. It can also go out the pituitary gland. It can go down the sympathetic chain. It can go down the spinal cord. It's not the same as vagus nerve stimulation when you put an electrode on the vagus nerve.
Yeah, right. Now, what was the ultrasonic option that you mentioned? What's that?
So focused ultrasound has been used to stimulate nerves. Focused ultrasound uses a special cone lens on the ultrasound probe to focus the beams so they hit a very, very small place. And you can adjust the power and the pulse waves, so that they literally vibrate the nerve, or they vibrate the molecules in the nerve fiber membranes, and it causes the nerve to fire action potentials. Let's be clear about that too. When you put an electrode on the vagus nerve, you're not driving electric current up and down the nerve like in a copper wire, which is, again, what many people assume. When you stimulate a nerve, you actually put in pulses of electricity, very short, very small pulses of electricity, which cause the voltage-gated ion channels in the nerve fibers to fire their own action potentials. So you're using the electric stimulators to cause the nerve to do its own propagation of action potentials. Focused ultrasound does the same thing, but it can do it from outside the body.
Got it. So bottom line is not a whole lot of ways to, truly do vagal nerve stimulation right now. Maybe there will be in the future, maybe a big focus, for biomedical engineers. Speaking of which, just in general, there's someone who's kind of obviously done some amazing work already, launched a new field of medicine. What excites you about the next 10 years of, I guess, aging and immune science, and what are you watching closely?
What we talked about, what you asked about, one of your favorite topics. I think inflammation and the role of the brain and nervous system in that are crucial. Now, it's interesting. You have sort of schools of thought about what aging is and why disease increases with age and why people have to die at all. And I'm not taking a position on one school versus another. It may be that some of the important theories of aging, whether it has to be with one signaling pathway or another, or one oxidation pathway or another, it may be that some of these important pathways actually enhance inflammation. And once again, we have to be careful of what we mean by inflammation. It's what I meant before. It's the overproduction of inflammatory molecules in various tissues that disrupt metabolism. It might be that metabolic dysfunction actually, and we already know this is true, we didn't talk about it, but you have inflammation, you alter metabolism, you get inflammation. So what if neural signals were part of that? Now, imagine for a minute that we had just to make a point here, imagine we had a magic solution that could dissolve every cell in your body, but not your nerves and not your nerve endings. If I submerged you in that solution and then pulled you back out, you would still look pretty much the same, because every cell in your body is surrounded by or in contact with a nerve ending. Think about that. I mean, our bodies are walking neural networks connected to our brains, which are active neural networks. So if that's the case, which it is, that means that when something happens in a cell, a metabolic change or an inflammation change, your nervous system is informed. That means your brain, your nervous system, can react to it. That means you can't take the nervous system input and output out of the equation of understanding aging. So if those metabolic changes or inflammatory changes are affecting neurons, you're going to disrupt the regulatory balance of things like the inflammatory reflex, which normally turns off inflammation. And if the inflammatory reflex is damaged, and now you have more inflammation in the body, you're going to end up with a vicious cycle. So these are not all the answers, but they are very reasonable questions. And as our tools, our molecular tools and neurophysiological tools, as they continue to advance, we're going to be able to study this more carefully. So for example, you can use a technology today, and we use it in my lab, called optogenetics, where you can make neurons in a mouse brain sensitive to laser light. And now you can because you put in a light sensitive channel from algae. If you now shine the laser light on the neurons in the brain of a mouse, you can selectively activate individual neurons. That means we can go in an old mouse and a young mouse with these genetic engineering methods, and we can say, in an old mouse, what happens to these neurons controlling inflammation in the liver or the spleen or the lungs or heart? And what is the influence on the progression of inflammation, which is dependent on these neural signals? These are fascinating questions that are answerable today with these technologies. And when we have these kinds of answers, we may very well be able to develop and invent new biomedical and bioelectronic devices to treat inflammation. That could change a lot.
Yeah. Well, Kevin, this is an absolutely fascinating conversation. I feel like I could talk to you for hours. If people are interested in these topics, what would be good resources for them to follow up?
Well, I would highly recommend my new book, and thank you for asking, Buck. My new book's been out a few weeks. It's called The Great Nerve. The name comes from what Galen actually used to call the vagus nerve. And in the book, I tell some of the stories we talked about here. Thank you for that. But I also tried to give enough information on some of the scientific background to the inflammatory reflex as a resource for patients who may have questions about this new technology, which turns out to be in some ways brand new and other ways rooted in years and years of work. And I even have a chapter in there called Frequently Asked Questions, ask your questions you can ask your doctor. And the answers are in there for the doctors. So it's written for everybody. It's written to try to form a basis of the dialogue. There's hundreds of end notes for people who want to dive in to the clinical trials and the science information. And I hope it can be a good resource for your listeners.
Fantastic. Thanks so much for joining us.
Thank you for having me on, Buck.
Thanks for listening. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe.